Hello, my name is David Brenin and I am the Chief of Breast and Melanoma Surgical Services at the University of Virginia, and it is my pleasure today to present our newest focused ultrasound ablation immuno-oncology protocol, Breast 54, titled Focused Ultrasound with Low-Dose Gemcitabine to Augment Immune Control of Early Stage Breast Cancer. But before we talk about Breast 54, it would be a good idea to assure that we're all on the same page regarding immune therapy to treat patients with breast cancer. Immune therapy has been demonstrated to be effective against certain breast cancers. Typically, these tumors have been triple negative, in other words, estrogen receptor negative, and have a high number of tumor-infiltrating lymphocytes. Unfortunately, this represents a minority of breast cancers, as most patients' tumors are estrogen receptor positive, and these tumors are known to be far less responsive to immune therapy and typically are considered to be immunogenically cold. In Breast 54, we hope to increase the immunogenicity of these minimally immunogenic cancers through the use of a combination of focused ultrasound ablation and a drug known as gemcitabine. Focused ultrasound ablation can cause an acute thermal cellular injury and is known to initiate a brisk local immune response. And in fact, our preliminary data from Breast 48 demonstrated just this, that local immune response precipitated CD8 positive T cells to traffic to the damaged area of the tumor. Unfortunately, shortly after the CD8 positive T cells traffic to the tumor, myeloid-derived suppressor cells also traffic to the tumor, and these MDSCs tend to tamp down the immune response that is being initiated by the CD8 positive T cells, and thus they are immune suppressive. So why use gemcitabine? Gemcitabine is a relatively mild chemotherapeutic agent that is used to treat patients with breast cancer and has been shown to decrease the number of myeloid-derived suppressor cells in circulation. It is our hope that if we can deplete the MDSCs in circulation, that they won't be available to traffic to the tumor after focused ultrasound ablation, and thus they will not be able to tamp down the local immune response induced by focused ultrasound ablation. In addition to the clinical data regarding MDSCs and gemcitabine, there is preclinical data that has been generated by Dr. Shabani in the Price Lab at the University of Virginia that demonstrated that focused ultrasound ablation plus gemcitabine was highly effective in a murine model at controlling both the primary tumor and lung metastasis in a breast tumor model. That brings us to Breast 54, the use of focused ultrasound ablation in combination with gemcitabine to treat patients with early stage breast cancer. This study is currently open and accruing at the University of Virginia. The study has 3 arms. In Arm A, patients receive gemcitabine only, followed by standard treatment. In Arm B, patients receive focused ultrasound ablation only, followed by standard treatment. And in Arm C, the patients receive a combination of both gemcitabine and focused ultrasound ablation, followed by standard treatment. Patients would be followed for 5 years, and tissue will be collected both before and after treatments. So for clarity, in Breast 54, there will be 3 arms. In Arm A, patients will receive gemcitabine alone. In Arm B, patients will undergo focused ultrasound ablation alone. And in Arm C, they'll receive a combination of the 2. Patients will be randomized 1:1:1 with a total of 48 subjects, and that means 16 patients in each arm. As Breast 54 is an exploratory study, we'll be looking at the primary endpoints of safety of focused ultrasound ablation, safety of gemcitabine alone, as well as the combination of the 2. And we'll be looking at the following primary endpoints: adverse events, time to surgery, and positive margin rate. There are multiple secondary objectives and endpoints, but they are too numerous to review due to the time constraints of this presentation. However, they are presented on this slide as well as the next. Patients that will be included in this study have early stage breast cancer, in other words, clinical stage 1 to 3 breast cancer. Their tumor can be of any receptor status, and if genomic profiling is performed, they should be at high risk. However, genomic profiling is not required in order to be entered into the study. For safety in breast 54, tumors must be at least 5 millimeters from the skin, and the rib to treatment target zone must measure greater than 1 centimeter. We've used the EchoPulse device for all of our breast cancer studies, and it consists of a computer-driven system comprised of an electronics cabinet, an extracorporeal probe mounted on an arm and moved by motors, a cooling unit, and an ultrasound imaging probe that is mounted within the HIFU transducer. Here is the business end of the device. This is the roboticized head. This is a cooling jacket through which cool liquid circulates to keep the skin cold during the treatment. This is the ultrasound probe that is embedded within the HIFU transducer. Again, we're only treating inside the tumor, and more specifically, the goal is not to treat the entire tumor, certainly no more than 50% of it. Here is a picture of the first specimen from a patient that we treated. This is after treatment, after the tumor has been excised, and you can see there is a necrotic portion of this tumor where we provided focused ultrasound ablation juxtaposed to viable tumor. And again, this is our intent. We're going to obtain biopsies for evaluation of the necrotic area and of this transition area, as well as of the viable tumor. To wrap up the presentation, I'd like to let you know that Breast 54 is currently opened at the University of Virginia, and we have enrolled 3 patients to date. We are accruing nicely, but we hope to increase accrual rapidly as soon as Theracleon provides an updated device, which should be soon. This updated device will have better imaging and will allow us to treat patients with smaller tumors. I'd like to thank the following individuals without whom we could not conduct this clinical trial. Dr. Patrick Dillon, who is the PI on Breast 54, Dr. Natasha Shabani from the Price Lab, who provided that vital preclinical data that I presented earlier, the Focused Ultrasound Foundation, Theracleon, the UVA Cancer Center, and their donors. Thank you for your attention.